Hi, I'm Dr. Eldad Elnekave. We are here at Rabin Medical Center. I'm going to be talking about doxorubicin-eluting embolization for treatment of desmoid tumors. And before I do that, let me describe the concept of treating tumors using their blood supply. So tumors naturally grow faster than normal tissue in the body. And to do that, they recruit their own blood supply. Now the blood supply in the body looks a lot like a tree. It has branches. And when there is a tumor that comes off one of those branches, it looks like it's developing a whole new tree from that one branch. So what we've learned how to do as a field in interventional radiology is navigate using small catheters into blood vessels that supply tumors and not normal tissue. So we're starting with that concept, we move into doxorubicin-eluting embolization. Doxorubicin is a powerful chemotherapy. It's red, hence the ruby in doxorubicin. And it's very effective, but again, very toxic on the heart, on the bone marrow, the skin, other cells. And so, on the one hand, it hits the tumor hard. On the other hand, it hits the person hard. And so over the years, people have found ways to limit the toxicity of the drug while maintaining its efficacy. And one example of that is Doxil. Some of you may have heard of using Doxil for desmoids. What Doxil is a doxorubicin molecule that's basically surrounded by little fat. It's a liposome. And the reason that works is that liposomes are naturally attracted to tumors. It's something called the EPR effect, the enhanced permeability and retention effect. It's a passive process. You inject these liposomes, they go preferentially to tumors, but there's still toxicity, as many of you have heard, with Doxil. Doxorubicin-eluting embolization is an active way to target the tumor. So we'll take the doxorubicin, which is red, put it onto a bead, had stuck on the bead, and then we navigate into that vessel that is providing blood flow to that tumor. And then we inject these particles into the tumor. They get stuck in the tissue, bringing a very high concentration of doxorubicin into the desmoid tumor with a very low concentration systemically. And this is the concept behind DEE. That's how it's different from Doxil. And of course, we've described how Doxil is different from just free doxorubicin in the veins. We first published on this technique in 2018 on children with tumors in the extremities. But since then, we've treated patients with desmoids almost anywhere. So inside the abdomen, inside the pelvis, on the chest wall, legs, arms. You know, the only place that we haven't treated and that we haven't seen treatment is in the face, the head, but I'm certainly not one to say that that's not possible. Treatment of desmoid tumors using DEE can be feasible, based mainly on the expertise of the interventional radiologists and the use of safe techniques to get particles and drug into the tumor and avoid toxicity. So this is really a case-by-case basis. The most important feature in terms of exclusion is that you have to have signs on an MRI that the tumor is really alive and not sleeping or dormant. There is no single answer for this. We've had patients who hardly noticed the treatment and patients who've required very little treatment, maybe 7 milligrams of doxorubicin, and those who have required 150 milligrams over several sessions. The level of pain depends a lot on the size of the tumor and how aggressive the treatment is. Here we tend to break down therapy into 2, 3, 4 sessions and provide smaller doses in a fractionated way, and that reduces the risk of having pain. In general, and when I say in general, we're talking about experience of around 30 patients. Recovery from pain or discomfort is seen within a week. For some very difficult large tumors in the belly, you might see that happen over the course of a month. The risks and benefits, the risks and side effects are very dependent on the location of the tumor. And again, that's something that needs to be discussed with the interventionalist treating you. We've been doing this procedure for about 6 years here in Israel at Rabin Medical Center. Over the past 2 years, we've had some collaborations with other hospitals, specifically Munich University Hospital in Munich, in New York with Memorial Sloan Kettering, and we've over the past year really seen interest and picking up of the procedure across the world, but in selected locations. So far, the ones that I know about, Hong Kong Children's Hospital, Prince of Wales Hospital in Sydney, Mayo Clinic in Rochester, Minnesota. And I'm quite sure there are others. I want to be clear, this is not a technique that requires specific equipment or really very particularly difficult expertise. It requires a dedicated interventional oncologist, and that can be found really in most tertiary medical centers. And we're here and happy to help discuss the cases as we do with anyone who is treating you. So first of all, Mazel Tov on the pregnancy. And what you really want to know is it safe to do DEE while I'm pregnant? And this is a really personal question to have with your physician. There are a few things to consider. One, we know that hormonal changes of pregnancy can accelerate the growth of a desmoid. So depending on where that is, you may want to take that into consideration, and this may be an important time to do treatment. In terms of toxicity, this is what we know. The dose that we generally administer on DEE is around 10% to 20% of what a person getting systemic doxorubicin might receive in the course of a week when they're getting doxorubicin for multiple weeks. The bottom line there is that the amount of doxorubicin that we use for treatment is low. Then the amount of doxorubicin that is released systemically outside the tumor is on the order of around 10% or less of what we deliver to the tumor. As a result, I think there is reason to be comfortable with the treatment even during pregnancy, but it needs to be discussed with the practitioner.